in the PDCC from the PHU for 5 years back, and he the working as the director post at the Chandar Hospital and experience more than 5 years in the pain management, exclusively in the pain management. He is doing very wonderful job in the pain management, and now going to proceed for the lecture. That is the there is the mechanism of the thermal, cold, and pulse radio frequency ablation. So, Dr. Amitesh, can now we proceed for that? And thank you.
Okay, sir, I'm sharing.
Dr. Amitesh.
Yes, sir.
Mm-hmm.
I'm sharing my screen, sir.
Yes, sir. Okay, sir. Proceed, sir.
Is it visible now?
Yes, sir. Public is actually winter regularly, so there is an able to visible video.
Pardon? Is it
Yes.
visible now?
Yes, visible.
So, good morning, everyone. Good morning, Anurag sir and Anil Paswan sir. Thank you very much for providing me an opportunity to have a discussion on this conventional and pulse versus the cooled RF. So,
Yes.
starting with the topic, my topic is how does it work, the conventional pulse and the cooled RF, and it will be followed by Dr. Sujeet Gautam and later by the Dr. Sidharth Verma in the next headings. So my topic is basically will be covered in three headings. First is the basics of radio frequency. Second, I mean, how does the radio frequency actually works? Second will be the mechanism of conventional, the pulse and the cooled RF, a new entity in the RF system is the cooled RF. And what are the various conditions or modalities in which the RF application is basically used these days. So going for the basics, so there are three modalities of radio frequency treatment. One is a conventional RF, second is the pulse RF, and the newer one is the cooled RF. The basic concept behind is there is a high frequency alternating current which is used to either interrupt or alter the nociceptive pathways at the various sites. So how does it do? In the conventional RF, alternating current of 100 to 500 hertz frequency is continuously applied to a target nerve. The aim is to produce a thermal lesion. So heating of the tissues causes coagulation. So how it does, the principle behind is when an RF energy is applied, the ions in the surrounding tissue, they cause friction. And these friction causes surrounding tissues to heat. And the heat of the surrounding tissue by conduction, it reaches the RF probe or the electrode. And
Amitesh, sorry to interrupt.
yes, sir.
Speak slowly and somewhat loudly.
Okay, sir. Sure. So the principles of ionic heating is once an RF energy is applied, the ions in the surrounding tissue, they cause friction. And this friction creates heat and in the surrounding tissue. And this surrounding tissue heat by conduction reaches the RF probe or electrode, which we use in the RF during RF. And there is a thermo probe located at the tip of RF and it reads the tissue temperature. So this is the basic behind. So the thermal field created by the ionic friction, that creates a voltage that induces an electrical field, and this electrical field is the fundamental physical quantity which governs the action of RF on the neural tissue that causes the conventional RF and the pulse RF. In the pulse RF, what the difference between the conventional RF and the pulse RF? In the pulse RF, the alternating current in 20 millisecond pulses is given at a frequency of 2 hertz, and there is heat dissipation because there is a big pause between the pulses which allows the heat dissipation, and the heating is further minimized by the electrode tip temperature, which is fixed at 42 degrees Celsius. So the temperature in the surrounding tissue is insufficient to cause a neural degeneration in case of the pulse RF. So the mechanism is not very finely understood in case of the pulse RF, and there is altered signal transduction to pain pathway. And a pulse RF causes only transient endoneural edema in contrast to Valerian degeneration by conventional RF. So what is the difference mechanism? What is there is a different mechanism in case of the cooled RF? And cool, the basic principle is the same, that a thermal lesion is applied by the application of energy at the electrode to target the neural structure. What is their difference is there is a water channel, water cooled RF system. It is applied through a multi-channel electrode. So continuous flow of water goes through that electrode, and this active cooling prevents the electrode tip gets heated from the surrounding tissue, and in meanwhile it allows the continuous flow of current and RF current. So there is a default setting of around 60 degrees C, which is usually fixed in the cooled RF, and it cools the electrode temperature immediately surrounding tissue. So if you go with the mechanism, in the both the RF and the cooled RF system, they work by ionic heating. This ion heating causes the friction among the charged molecule, and this friction creates heat, and it deactivates the nerves responsible for the pain signals. So the mechanism is same in both, like the ion heating causing friction of the charged particles, creating heat, and leading to thermal ablation. So what is the difference between the standard versus the cooled RF? How they differentiate between each other? The challenges with the standard RF is when you see there is multiple variabilities in the neural tissue. As you see in this diagram, it is shown of the genicular nerve. The lesion created by an standard RF, they are unable to capture all the target nerves in a single attempt because usually there is a variability in the neural structures. So with the standard RF, the ionic heating is maximum at the tip of the probe and the tissue surface, while at the periphery, the temperature is much lesser. Like you can see at the tip, the temperature is around 80 degrees C, but at the periphery, the temperature is around 40 degrees C. So if there is a variability in the neural tissues, uh, then there will be sparing of the neural degeneration, which you won't want, and the lesion will be elliptical shape. So the diameter of the lesion is also smaller with the standard RF. It is usually of 4 millimeter diameter. Because of its size, shape, and the lack of distal projection, the standard RF has a limitation. So this thing has been covered by the cooled RF system. So similarly, the standard RF too small to reach all the targeted nerves which you actually want. So what does a cooled RF does? A cooled RF, it increases more than 5 times the larger volume it covers, and there is angle independence of the probe. You in standard RF, you have to keep the needle at the. It has to be parallel to the nerve. In the cooled RF, you have the angle independence of the probe, and because you can cater a larger volume. You can see in the periphery also you can have a temperature of around 80 degrees. So, what all conditions do in radio frequency? What all the conditions are the one in which we normally do a radio frequency? Radio frequency can be applied in the low back pain or neck pain or knee pain, hip pain or shoulder pain, and most commonly we do in trigeminal neuralgia. So, in the next topics, I will cover some evidence-based studies, what all in these conditions. So in the commonly low back pain, usually it's not only the sciatica or the disc bulge. The most of 40% of the cases of the low back pain, they are due to either due to facet joint dysfunction or due to sacroiliac joint dysfunction. In both the conditions, the radio frequency thermocoagulation had been quite a handsome in relieving the pain. So, like lumbar facet joint medial branch block, you put a needle at the junction of the superior articular process and the transverse process. If you can make out the Scooty dog view at the eye, if you can recognize the eye of the Scooty dog, there you do a diagnostic test, and if with 0.5 ml of diagnostic test the patient gets relief, then you go for the RF of the medial branch block. So a study by the Barahona and Olvera literature review, they have shown that in radio frequency thermocoagulation and chronic low back pain facet joint, They came to the conclusion that lumbar medial branch of facet thermocoagulation is a minimally invasive procedure aimed for the treatment of the facet joint, and it has been shown that it is an effective tool for the low back pain and provide a better relief, more predictive relief than the intra-articular injection. Similarly, if a patient comes of a hip pain, gluteal region pain of having a sacroiliac joint pain, the pain usually it is more while sitting or turning on the bed, and you do test and you diagnose it to be a sacroiliac joint pain. You try with the conservative treatment. You do the intra-articular injection. The patient is not relieved. The next option would be a better one will be a sacroiliac joint RF. A study by Dr. Vinay Kumar Biswas on the water-cooled radiofrequency neuroablation for sacroiliac joint dysfunction. He stated that he came to a conclusion that the lateral branches of S1 to S3 dorsal root, they are frequently implicated in the SI joint pain. The lateral branches of S1 to S3 dorsal roots are frequently involved in the SI joint pain, and these lateral branches they have an unpredictable distribution across the posterior sacrum. So because of this unpredictable distribution, the conventional RF or the pulse RF is not that beneficial. Rather, a water-cooled RF can treat a greater volume and a larger area it can cover. So there can have a adequate neuroablation even in erratically coarse sacral lateral branches supplying the SI joint. So another condition like neck pain, in a neck pain, if there is cervical facet joint pain or cervicogenic headache, radiofrequency ablation can be tried. A systematic review, as a very beautiful systematic review by Falco and Manichanti, a systematic review or therapeutic effectiveness of cervical joint intervention. He concluded with the fact that cervical median branch block is has a fair evidence for the better than the intra-articular injection and anesthetic steroids, which have a limited evidence. RF application can be done in shoulder joint pathologies like frozen shoulder or knee pain, osteoarthritis in patients who are not getting relief with conservative treatment, or they don't want to undergo for surgery, or they want to take some time to go for the surgery. So RF application, RF of the genicular nerve can be tried in those patients having a knee osteoarthritis. Suprascapular nerve RF can be tried for shoulder pain or the frozen shoulder patient. RF for articular branches of femoral and obturator nerve can be tried for the hip joint. This is this I have done in my OT. Genicular RF, cooled RF. These are the cooled RF needles which are placed at the three sides. One is the lateral femoral, medial femoral condyle, lateral genicular nerve, lateral femoral genicular nerve, and the in, superomedial superolateral genicular nerve, and the infromedial tibial genicular nerve. At 3 points, you do genicular RF. And as you can see in the C-arm view, the points of the needle in the lateral view also the in the lateral view, the needle position should be at the junction of the anterior 1/3 and the middle 1/3 at the shaft of the femur. For the shoulder pain, on a study by the Orhuru and by the radiofrequency ablation of management of shoulder pain, he concluded that shoulder RFA may provide a significant benefit in the management of the chronic shoulder pain. Similarly, in trigeminal neuralgia, also the pulse RF and the conventional RF had been tried. My personal experience, I would that is a conventional RF is better than the pulse RF in trigeminal neuralgia. To summarize, there is a good evidence for the lumbar facet joint pain. There is a fair evidence for the cervical facet joint pain, and there is a good evidence for the knee pain. Thank you so much.
Hello, Dr.
Hello, sir.
Mitesh.
Yes, sir.
I would like to know that suppose you give the option of the cooled RF
Yes, sir.
or conventional RF in case of genicular nerve, which would like to prefer?
I would prefer cooled RF, sir. Cooled RF has a greater, bigger lesion. I have my
Actually, in our BHU, actually cooled RF, actually there is a tiny nerve. So this is effective even in the genicular nerve, sir. And this is so much expensive. Cost of the RF electrode 3,000. The cost of the cooled RF is 30,000. So cost matter is there. So I think there is a lesion and produces same efficacy. I think more than 6 months.
Dr. Paswan,
Yes.
we will take
Uh-huh.
all the questions in the last. है ना? Please, please continue the session because other speakers
Okay.
are waiting. है ना?
Okay, sir.
Please.
Okay, sir.
Thank you,
Hello.
So now I take the liberty to thank both Dr. Anil Paswan and Dr. Amitesh Pathak for his wonderful talk. Dr.
Okay.
Paswan, would you like to say a word about Dr. Amitesh presentation in which
He
he
has
has
done no, undoubtedly he has done very good job and very nice presentation. Thanks a lot for that. And I would ask the question later on. Very nice.
yeah, thank you.
Okay, sir.
So
Thank you.
now I invite our second moderator, who is the man who has started and broken the ceiling by starting first DM course in the world in pain medicine at Rishikesh AIMS, All India Institute of Medical Sciences at
Okay.
Rishikesh.
Make
Uh,
a big hand.
yeah, yeah. So, so
Big job.
I invite Dr. Ajit to please take over and introduce our next speaker for the radio frequency session of Indian Society of Pain
Thank you,
Clinicians.
boss. Good morning to all pain clinician member, and I like to inform Dr. Sujeet Gautam is a additional professor in GPGI Lucknow, and his topic is factor affecting the size of lesion of the RF size. So, kindly start the lecture of. Uh, hello, Sujeet, start your lecture. Thank you.
Dr. Sujeet. Dr. Sujeet, you can unmute yourself and share your screen, please. Dr. Sujeet.
Actually.
Dr. Sujeet.
Hello. Hello.
Dr. Sujeet. Hello.
Hello.
Okay, okay, okay. Okay, okay. आ गया. हाँ. Actually, there was some technical problem with Dr. Sujeet. He had now joined back and coming in a moment. Sorry for the technical glitch. There are few things which we pain physicians don't know about. Please,
Boss, I'm
welcome.
audible.
Yes, yes, you are. Please share your
Okay,
screen.
sorry, my screen was has gone unreactive as you were rightly mentioning. Some technical glitch was there, so now I'm sharing my screen.
Yes, please.
Kindly, can you make me co-host, please now?
Yes, yes, you are co-host.
No, basically, I have logged out and then again logged in.
Okay, okay, okay. Just a moment. Yes, I have made you co-host. Yes,
Okay,
please.
thank you, boss.
Dr. Sujeet, is there any problem?
Yeah, am I audible now?
Yes, you are audible.
Am I audible?
Yes, yes.
Yeah, sure.
Yes, sure.
Sorry for some interruptions in between.
No
So
issue.
we have included this topic for the session of the practical considerations of radiofrequency lesioning, because often when we do our radiofrequency lesioning procedure, we are usually very happy that now we have done this procedure and the patient should be having pain relief for some long duration of time. But what happens that patient comes back to us within a period of say 10 to 15 days and say there is no pain relief, and suddenly our situation resembles to the situation of this gentleman in the current scenario, because patient is not having pain relief. So it is very important that we should have in our mind a list of the factors which basically affect the size of RF lesioning, and with the help of which we can improvise the outcome. So I shall be discussing these factors one by one. First of all, the needle characteristics. Well, needle placement is one of the most important factors as far as thermal RF lesioning is concerned. And as we can see that the lesion of thermal RF, the length of the lesion is actually the length of the active tip. So our needle should lie parallel to the course of the nerve. However, if our needle is lying perpendicular to the nerve, a very small portion of the nerve will be lesioned by thermal RF lesion. So it requires a great amount of operator skills to position the nerve to position the needle parallel to the nerve, and this can be very interestingly explained with the help of this example of thermal RF lesioning of medial picture is a schematic diagram of medial branch passing in the groove between the SLP and the transverse process. Now, we position the needle parallel to the nerve. And if we look at the C-arm pictures over here, this is how the needle appears in the fluoroscopy pictures. However, if we position the needle perpendicular to the nerve, a very small part of the nerve will be lesioned, giving rise to short-term results. Now, the next important factor is the needle proximity to the nerve. Now, as per this equation, thermal energy delivered at a point is inversely correlated to the fourth power of the distance from the radiofrequency needle. And this complex equation becomes really simple to understand if we look at this picture, where looking at the proximity of these two individuals, we can clearly say that there has to be some spark between them as compared to the other. Needle and the distance between the nerve and the needle. Now, how to assess the proximity of the needle to the nerve? We can assess with the help of nerve stimulation, as we do in our routine OT procedures. And with sensory and motor stimulations, one can assess the proximity of the needle to the sensory and motor fibers respectively. Now, the parameter which helps in ascertaining the needle proximity to the nerve is the voltage that is required to stimulate a nerve. Now, 0.25 volt is the minimum voltage that is required for stimulation, and as this voltage increases, it means that needle is lying at a greater distance from the nerve, and at 2 volts, approximately the needle is lying approximately at 1 centimeter from the nerve. So we need to reposition the needle if our needle position is somewhat at a greater distance from the nerve. Now, coming on to the needle characteristics, these are the 3 important needle characteristics which are important. First of all, the thickness of the needle. Now, the maximum width of a thermal RF lesion is approximately 3 to 4 times the width of the electrode tip. So that means as the thickness of the electrode increases, the lesion size increases. So to give you 2 examples, an 18 gauge electrode produces around 2.2 mm lesion radius, and 22 gauge electrode produces a lesion with radius of 1.9. Length of the active tip, the lesion is as long as the length of the active tip. However, if the needle is somewhat curved or blunt, the lesion may extend up to 1 electrode width distal to the needle tip. Another important advantage of using a curved needle is that we can produce a larger size lesion. As you can see in this picture, one lesion has already been produced surrounding the red circle, and afterwards we have rotated the curvature of the needle towards opposite direction, and another lesion is produced. So simply by rotating the needle curvature to opposite directions, we can increase the lesion size, and this fact is very important when we are doing procedures where needle cannot be positioned parallel to the nerve. So like lumbar sympathetic RF lesioning, needle is lying parallel to the lumbar sympathetic chain, so we can rotate the needle to produce 2 lesions and thereby giving a larger size. So now if somehow the needle is lying parallel to the nerve, we can simply move the needle out to produce a second lesion to increase the lesion size. Now, coming on to the radiofrequency generator parameters. First of all, to the duration of lesioning. Well, the thermal energy bears a logarithmic association with the duration, and the most significant lesion expansion occurs in the time period up to 60 seconds. However, as we move from 60 to 90 seconds, small but significant growth occurs. Hence, it is recommended that most of the lesions are recommended to for a duration of approximately 90 seconds. Regarding temperature of lesioning, most soft tissue coagulates in the temperature range of 60 to 65 degrees Celsius, and when the temperature of the electrode is in the range of 80 to 85 degrees Celsius, this temperature of 60 to 65 degrees Celsius can be achieved at a distance of approximately 2 electrode width. Now, coming on to bipolar RF lesioning, this simply means that 2 radiofrequency cannula are placed side by side. Thereby, electrical field is generated between these 2 needles. And as a result, the lesion generated by the 2 needles joined together, giving rise to a larger size lesion overall. So to give you an estimate, the lesion produced by a bipolar lesion produced by a 20 gauge radiofrequency cannula having a 10 mm active tip and 10 mm spacing is approximately 12 by 15 by 8 mm. So a very large size lesion can be produced by this technique. Now, so what are the basic advantages? One, I have already told, large size lesion, which is approximately thrice the size of the lesion produced by a monopolar RF technique. And another specific advantage which is used in the SI joint lesioning is that we can produce a connected strip-like lesion so that we can lesion a larger area as in case of sacroiliac joint. So now these were the factors which are basically present in any textbook, any standard textbook of pain medicine. Now, during any RF procedure, I used to thought that is there any specific role of local anesthetic that we inject just prior to making RF lesioning? Well, I came across 3 specific studies. I would like to mention the conclusion of these 3 studies. Now, first study described the relationship of lesion and the fluid pre-injection in case of monopolar RF. And it concluded, and it says that it alters both final lesion size and the time required to achieve maximum lesion size, hence extending the duration of radiofrequency lesion beyond 90 seconds when fluid is pre-injected resulted in reduced lesion variability. What they want to say is that when we inject fluid and make a radiofrequency lesion afterwards, there is somewhat variability in the size of the lesion. And this variability reduces when we extend the duration of lesion beyond 90 seconds. So no problem, we usually make our lesion beyond 90 seconds in most of the cases. Now, second article was somewhat interesting, where they have studied the properties of sodium chloride fluid pre-injection and the lesion size. And what they concluded was that increasing sodium chloride concentrations significantly increases the lesion size as a result of reduced impedance. Now, this was very important because if we include sodium chloride as a component along with local anesthetic, there is a possibility that our final lesion size is going to increase. And finally, fluid injection and lesion size during bipolar radiofrequency treatment, what they said was that pre-injection of any fluid increased the odds of consistently achieving a continuous lesion between the electrodes. In simple language, we can say that with bipolar radiofrequency, a continuous lesion can be produced at a larger distance. That is, needle lying at a larger distance, and we inject certain fluid, lesion can be produced at a larger distance. And another fact, injection of any fluid containing sodium chloride, including lidocaine, significantly increased the lesion size over the observed with injection of water. That means sodium chloride injected has got a better tendency of increasing the lesion size. So these are all the factors which I have included in my presentation. And to conclude, what I would like to say, if we want to maintain this mood of happiness towards the end of any radiofrequency lesion, we need to consider these factors whenever we are going to produce a radiofrequency lesion in our mind. These are the important factors, and definitely our outcome are going to improve. Thank you very much, and sorry for the initial technical glitches.
Thank you, Dr. Gautam. It was a wonderful presentation. Whosoever have seen it must have understood that how much pains you have taken for making this presentation very useful for both pain physicians working in the field, pain physicians we are getting prepared, and also for the residents of anesthesiology. So I again request Dr. Jeet to take over the program further ahead with the introduction of our last speaker of today, Dr. Sidharth Verma. Dr. Ajit, please. Dr. Ajit? Acha, sorry, it's my mistake. Dr. Anil Paswan has to introduce our next speaker. Dr. Paswan, please.
Okay.
Yeah.
Hello. Good morning, Dr. Sidharth. Hello. Hello.
Hello.
Yes, was audible.
Yeah,
Hello.
yes, I can hear you, sir.
Hello. How are you?
I'm good, sir.
Okay. And very nice and good morning. Dr. Sidharth Verma. He is exclusively, actually, Dr. Sidharth Verma, working as a pain physician last more than 6 years. And he, after passing the MBBS and MD, he has joined as the PDCC in the BHU and also in the abroad. He has took a lot of degree from in pain physician as a pain physician, and right now he is working in the as a pain physician in DY Patil College, Navi Mumbai. So okay, Dr. Sidharth Verma, now proceed for that. Okay, thanks a lot. Now proceed, Dr. Verma.
Thank you, sir, for the kind introduction. And today, I'm very honored and privileged to be invited to this presentation of Indian Society of Pain Clinicians, a body which was formed for promoting the structured education in pain medicine. And I'm very happy that today we have with us our mentor, Dr. Veerastogi, along with our senior colleagues. So I'll start now. So my talk is divided to two topics. First is how to avoid RF failure. So a lot of us have encountered, many of us are using the RF, and I think Dr. Sujeet's excellent presentation has made my talk very easy. So just to, okay, so I will take you through the background, and then I will mention about why it's so serious for RF and some tips and tricks to avoid the failure in RF. So
Sidharth,
what
sorry
we
to
know,
interrupt you.
yes sir.
Sorry to, basically, Hindi translation is coming at the lower part. If you can switch it off. Hindi translation towards the lower end is coming.
Okay.
Whatever you are speaking, it is basically being translated in Hindi.
Yes sir. Okay. Okay sir. So now is it okay? Better sir? Yeah, okay. So we already know about the lesioning and the ablation zone and everything, which has been already explained. We have seen the thermographs or the this diagrams which explain the temperature, lesioning and everything. So the important thing to note here is about the science of the RF as well as cooled RF. So this is a picture which shows the difference between both, and you can see that there is a water outlet and inlet which is in that tip of our all important tip of the RF cannula, and this is why it is very important, and these tips will be used to prevent the failures. Now if you see, this is some physics, but you need to understand if you want to avoid your failures. So there are 4 components which are involved while the RF lesioning is happening, and they are divided into, for simplicity, into Z1, 2, 3, 4. So one is the ablation electrode and tissue interface. Another is the impedance of the electrode. Impedance is the resistance to current. Then there is a body subunit, and then there is a body subunit interface. So whenever the current passes from one medium to the other, this is the time when it produces the heat, because it is changing the medium. So if you see, this is your RF cannula tip, and you know that only the tip is going to generate the lesion because it is the metal one, and behind it is a Teflon coating which will prevent the other structures from getting burned. So this diagram simplifies what I have explained in the previous picture, that there is this body subunit interface. So it is the connection with the rest of the body. This is with the electrode element, and this is the electrode tissue interface. So if you, this is the electrode, I hope you can see my mouse. So this is the electrode, and this is the tissue, and this is the electrode tissue interface. And this is where the heat starts to generate when the current flows. So tissue temperatures, they are produced by different current flows. They are proportional to the size of the letter T. So if you can see, in bone it is minimum, in fat it is a little higher, and it is the highest in the skeletal muscles. So if you can see, the size of arrows is also proportional to the magnitude of current flow. So you can see the highest current is flowing in the skeletal muscle, then comes the fat, and then comes the bone. So now it is not very difficult to imagine that the bone will get heated up the least, the fat thereafter, and the skeletal muscle in the last. Now why it is important? This is important because our nerves, they are lying in and covered with this fat. So there is a fat layer which you have to penetrate. Okay. So that's why this portion should be very close, as Dr. Sujeet mentioned. It should be very close and probably parallel, preferably parallel to your nerve where you want to put the lesion. Okay. So this is how the current flows. So this is your cannula. The current flows from the cannula to the body. And if you see, the tissue with good thermal and electrical properties for RF heating will have more heating, and the tissues with poor thermal and electrical properties for RF heating, like fat and bone, will have the poor heating. Okay. So in addition, we have some additional things to note, which is that the this heating or this current is not uniform in most cases. It is unidirectional. However, this can be improved if you have a different machine like the cooled RF. Okay, so you can have a greater arc with higher density with these models, or you can use the multiple lesioning, or you can use, as Dr. Paswan was saying, that he's using is because of cost issues, that also can be used. So moving ahead, This is a picture on your right. If you see, this is a lesioned skeletal muscle. So you see the skeletal muscle is lesioned to a higher extent. Then there is a dense adipose tissue, and you can see the lesion size, which is smaller here. But the point to note here is that your nerve lies here. That is in this dense adipose tissue or surrounded by the layer of the fat. So this is what you have to penetrate. So this has already been explained. So I'll skip this. Now going ahead, so just see what difference it makes in the cooled RF versus a standard probe. So see these zones. See 1, 2, 3, 4, 5, 6. On the left side is the normal thermal heating. On your right side is the cooled RF. So in many cases, you see this zone number 3. This is the zone of water cooled RF which is being created. And as a result, whenever you use a cooled RF, you can be a little away from the nerve also, because then also you will catch the nerve. If you are using a standard RF probe, you have to catch the nerve in the area. This LZ is mentioned, that's the lesion zone. So just outside the zone 2, 3 and 4, this is the lesion area. However, in this area is much bigger because it starts from the end of 3 now and it goes to the this 7 zone. Okay, so you need to understand this difference, and that's how you can apply this in your practice. So now coming to some questions. I know all of you are seeing there, so now get ready to type something in the chat box. So I think Dr. Sujeet has mentioned what is the frequency of the RF. Can you type in the chat box? Okay, while you get ready with this thing, I'll answer this question. So it is 250 kilohertz to 1 megahertz. Now, what is the voltage? I will answer this also. It is a few thousand to 800 volts. This depends on. I'll request all of you to mute your this thing. A lot of disturbance is coming. Yeah. So it is few thousand to 1800 volts. And now, please type this answer whether the RF it runs on AC, but in the body whether it gives an AC or DC and why. So alternating current or direct current, what does it give? Okay, I'll answer this question also. It gives a direct current because with alternating current there is a chances of redox reaction, which does not happen with a direct current. Now, how does the tissue get heated up? I think we all know the answer. So I will just still I would like to ask you, how does it get heated up? Can we have any answers? Okay, few people are typing. So meanwhile, I will
method, heating the frictional method.
Yes, so it is for like how a ceramic cup gets heated up in a microwave oven. So the heating is resistive plus conductive. So it offers the resistance to the flow of current. That's how also it gets heated up, and by conduction also. Conduction means you are in touch with the hard surface. That's how it gets heated up. So now let's come to the important point. Why 80 degrees? So there is no specific answer to this. The answer is that this is the maximum that the earlier systems could generate. Okay, so that's why we have the leaning till 80 degrees, because if you see the temperature at which your nerve gets deactivated, it is only 60 degrees. So in 60 degrees you will achieve the nerve lesioning, but 80 degree was maximum, and all the equipment generators, they wanted their lesions to succeed. That's why this was kept at that time. So now, what is the seriousness about avoiding the failures? The failure has to be avoided because the RF technology, it involves some risks. So what are these risks? So these risks are a lot of money is involved. So it's not a cheap technology. You have to spend money, and then you have to justify the use also of this money. Then, since it is not done very frequently, so for example, this is a quotation, this is a case series of only 20 cases, and this was published in a PubMed journal. So you can very well imagine that the volumes are very low, so we have limited data in literature. So whenever you go and search on the effectiveness, you will find limited data, and at the most 1 or 2 level 1 evidences. And there can be some side effects also of your techniques. To add to this, there is also a risk with the technologies, in that the size of the cooled RF cannula is 1.14 millimeters, because it's a 17 gauge cannula, and the size of the normal RF needle is 22 gauge, that is 0.64. It's a double difference. So then why we should take a risk and go for a better technology, or why we say then that the cooled RF is important? I'll take you to that also. So some tips and tricks are, as mentioned, you need to be very careful about the placement and the patient selection. The patient selection is the number one trick to avoid failures. So you will ideally select a patient who has a very clear-cut clinical diagnosis, and it is not for experiment. RF is not for your experimentation. You can experiment with an injection of a local anesthetic for a diagnostic procedure, but definitely not with an RF. So if you are sure, then you can go ahead with the RF. So patient selection is important. Number two is, see this picture, it shows on your left is the electrode with the medial branch. So this is showing the RF regioning of the medial branch. So you need to be placing your electrode in contact with the median branch, which is below this the layer of the epimysium, and that is, you cross the muscle and then you reach the adipose tissue where this medial branch is lying. If your RF cannula is lying above, see your picture on your right. So if your electrode is above, then it has to cross this adipose tissue layer, and you very well know when we cross the layer what happens. The current gets dissipated as heat. So all the heating will happen away from the medial branch, and hence you will not be able to grab the whole of the medial branch, and this will lead to failure. This has already been explained in the previous slides. So I would like to emphasize that the placement is very important. Just like how this guy has to place, just imagine how difficult it is for him to place this. So similarly, you have to be placing this thing as well. Another thing is, the patient will come with pre-formed notions. More and more our patients are searching on Google. So they come with pre-formed notion that their RF will work, and they will many times tell you that, okay, you do the RF in the first instance only. But you need to explain to these kind of patients that there is a high chance of failure, and they risk losing their time, efforts, and money, everything, if they are not very sincere in this. Okay, so a proper evaluation and a correct diagnosis, followed by correct needle placement and the technique, along with the correct equipment, is all key to the success of your procedure. So if you evaluate everything, then probably you will find that the machine is worth its benefit, and it actually comes out to be cheaper than what you will otherwise your patient will go through. Okay, so these are some pictures which show the exact lesioning points. So if you see, we have to lesion the nerves at exact point which are confirmed by the stimulation as well. To double check, we stimulate with the help of the stimulator, and we do the sensory as well as motor stimulation. Sensory stimulation is to make sure you are 100% sensitive, and motor is to ensure you don't lesion the motor nerves. So this diagram shows how closely you should be lesioned in the you should be placed in the groove to achieve the adequate lesioning. So just to illustrate how a small difference can make your procedure success or failure, just see this difference between L4 and L5. So I have quoted this from a paper which they studied both the things. So if you see, this is the L5 body, this is the S1 body. So the direction of the needle is different in both cases, and this is this square, this rectangle is the area where if you are placed, your chances of success are there. If you miss this rectangle, then you will miss the lesioning and your patient will not have any relief. Now you see, this is the facet joint, and this is the area for the L5 L4-5 facet, you can call it. And if you see, this is the L5S1 facet. Here it is a bit lower than L4-5. So you can very well imagine that if you have a slight margin of error, then probably you will not have a proper lesioning. In addition, to make your needle parallel to the nerve, your medial branches are running like these three lines. If you can see, so you have to come at a 15 to 20 degree angle from the, you can say from a vertical line which is drawn from this. And if you go straight, you will never be able to make your the cannula parallel to the median branch. So these two things are also very important if you want to place your needle in the close proximity. Otherwise, you may encounter failure. And I will like to repeat this picture. If it is not in close proximity with your medial branch, then it will result in poor lesion, and hence your procedure can fail. Now coming to the last part of my talk, how can RF transform your pain practice? So it is just like this caterpillar. So I give an analogy to my students. This is you without the RF, and this is you with the RF. For a pain physician, this is the difference, because RF adds a new paradigm to your practice. and a lot of things which are happening with your practice which are not so which are not making you happy, that can be taken care of with the RF. So how it happens, I will explain. So some common problems are, first I will discuss the patient related problems. So number one is less and less, many physicians they complain that the patient load is very less because the duration of relief is less, the cost of treatment. Many today also there was a talk on cost of treatment. So this is the number one question which bothers the physician. And number two question is peer related. So many anesthesiologists will say that why RF and what you are doing differently. If you don't have an RF, if your pain physician is working without RF, then how do you differentiate yourself from your fellow anesthesiologists who are experts in doing the diagnostic procedures as well? Then there are other specialists who are also started doing the diagnostic procedures now. So you have your colleagues from other specialties. So this RF is something which will make you a little different and will add something to your training, because you need to be trained in RF. You cannot just start using RF like that. So this is also another point. Another point is admin related. Why they should promote the services of a pain physician when you cannot give the definite results. So you have to be more definite, you have to be specific, and you have to demonstrate patient specific, patient benefiting outcomes to your admins. Another problem is self related, that is your training, your confidence. Many of people, they start asking medical legal things. Then your money and finance issues, these are all self related issues. So how RF helps in all of them? So let's talk about the patient related issues. So say for example, a patient comes to me and I give him an option that, okay, we'll go for a diagnostic procedure, but and we'll add a steroid to it, which will make it, a therapeutic, but we don't know how long the relief will last. Versus you give him an option of a definitive, say 6 months to 1 year of relief for sure, with a small incidence of failure rate, which he will know immediately after the procedure. Okay. So then that makes a hell lot of a difference. Try telling this to a trigeminal neuralgia patient and you will know how this feels. Okay. Now comes the cost of treatment. So many people ask this question for a pain physician. This is a very important question. The patients will not afford this kind of treatment. So let me tell you, if you can actually provide good results to your patients, the patients will definitely afford the treatment. For those of you who are working in government hospitals, if you can demonstrate effective results. So this is a difference which an RF makes by increasing your percentage of success. Let's come to the peer related issues. So a physician working with RF is, I don't actually think that if somebody is not working with an RF, you can actually offer the complete gamut of the treatment options, which a pain physician can offer. So this differentiates you from all the other people who cannot use RF. So this is a very important technique. The anesthesia training does not teach us how to do RF, but a pain physician training, you are trained to do RF. So this is a very important differentiating factor which can help you differentiate from your peers. So let's go to admin. Any admin, if you are your clinic owner or if you're working in a government hospital, you are working with an HOD, or you're working with your institute director, or you're working in a corporate hospital with a CEO, anybody will give you a good chance to work at their patients only if you can demonstrate positive outcomes. So these positive outcomes are backed in RF. You have seen a lot of papers. So we have ample data to support the evidence and to support the use of the RF in all these cases. So I think it will be much easier for you if you're already working with RF. Now comes self-training and self-related and self-confidence related, medical legal related. So these issues will be solved by the help of RF, because if now you have differentiation amongst all these first three factors, so this will give you a lot of confidence. And since you are now medically trained, there will be no medical issues, and money finance issues will automatically be solved, because you will be doing more procedures, helping more patients, making a difference in patients' life, and then you concentrate on the making your patients better. Money will automatically follow. You need not to consider about all these issues. So use of RF is a win-win situation for everybody. It will definitely make your patient, your admin, as well as you all happy. So to summarize, you can start with these next steps. First is, you want to read. You should read the latest papers on the RF. This is a very recent paper published few days back or probably a month back. So this is the consensus practice guidelines on intervention for the lumbar facet pain from multi-specialty national working group. Many of you would already have read this, but for the people who are considering, who are on the fence, considering the use of RF, probably this is a good point to start. It summarizes the evidence and gives you a very clear picture of where you are going. Next step is to think of the best pain physician you know of. Just think, do they use RF, and then make the choice. So now another audience question. So this is very important. Many of us want achieve good things in life, like this car. So all of us will say that, okay, we want to achieve this car. So how many of us are of the opinion that we want to achieve all good things in life? So can you type in the chat box and let us make it a little interactive? Because I think there are some chat options which I can see. Yes, we have some people who have typed. Okay. Okay, these are all questions. So to achieve anything, including whatever your aim is, you need to put in some effort. So for example, if you want to achieve this car, then you have to put in the effort and put in a lot of money for this. Okay. So this effort is the first step which will stop you from doing anything. So for those of you who are already convinced about the RF, please consider making this first step. And probably then your happiness scale will go on 10 on 10. Thanking you. If you have any questions now, I think we'll go on to the question answer session.
Thank you, Dr. Sidharth Verma, and nicely explained the how have a good and effective result by the RF machine. And without RF machine, it is not possible to start the pain clinic. And very nicely elaborate the patient selection is very important part. Second is the needle. Where is the needle? What are the position of needle? What are the distance of the needle from the nerve? And this is the most important, the size of the needle. This is the most important part. Thank you, Dr. Sidharth.
Thank you, sir. I'm sorry we have exceeded a little time, but I think this was required for my.
No need to be sorry, dear Sidharth. It was a very
nice.
elaborative,
very elaborative,
very useful presentation, I believe, for all of us. And all three presentations of today by Dr. Amitesh Pathak, Dr. Sujeet Gautam, and Sidharth Verma, they have been, I think, very useful. Now, I would like to take questions by the audience to one by one. So please, I request all three speakers of today to be braced with the questions. So there is one question.
Dr. Paswan sir had a question in the beginning.
Sir. Actually, I would like to ask the question, Dr. Sujeet. Sir, bipolar RF means you should have two RF generator machine to produce bipolar RF and start simultaneously. Yes, liking that. Supposed to speak, sir. Hello, Dr. Sujeet.
Yeah, you are asking that we need two machines for bipolar RF. Is it what that you are asking? No.
Yes, is two RF machine.
We don't need two RF machines for producing a bipolar RF.
And second, actually RF machine have actually, sorry to say that, we have one single probe RF machine. Many of RF machine have 4 probes, sir. Actually, what are the amount of fluid you should like to put into at the time of RF, sir, to produce large lesion?
You are talking that what are
the amount of fluid you are supposed to produce a large lesion?
So you are asking that what amount of fluid we should inject as a part of fluid pre-injection to increase the lesion size. Okay. Yeah. So what the authors have recommended is 0.7 ml in case of monopolar RF, and for a bipolar RF lesioning, 0.7 ml with both the needles. What they have done, why they have chosen 0.7 ml is that 0.5 ml was occupying the dead space of the needle, and 0.2 ml was coming out of the needle. So this is what they have mentioned. So in the latest article, in the last article of their series, they have mentioned it as 0.7 ml.
Okay, thank you, sir. And one question is that, sir, in case of genicular nerve, Hello,
Yes,
Dr.
sir.
Dr. Amitesh.
Yes, sir.
Yeah, I would like to ask Dr. Amitesh that suppose you are doing a cold RF with genicular nerve, then how much is this is effective as comparative to the conventional RF?
Sir, with my experience, what I have seen with the conventional RF and the cooled RF system, the cooled RF one had given a better result. It has not much studies had been because it's a newer entity, not much studies before the evidence is there. But still,
Okay.
I have done around 35 cases of cooled RF in genicular nerves,
Oh,
and
shit, my God,
experience of
good, very nice.
1.5 years, I have seen it has got a fantastic result. And I guess around 2 years of result is there with the cooled RF. And with the
Uh,
genicular one, 6 months to 1 year experience I had. It might vary with the person to person.
Associated with PRP injection, cold RF plus PRP. Yeah, only PRP. Yeah,
Only
only cold RF.
cooled RF. Only cooled
Only
RF.
cold RF give the very good nice result.
The results are good.
Along with that, only what we are doing, only cold RF or along with intra-articular injection.
Only cooled RF. Only cooled RF.
Thank you, Dr. Mitesh, and thank you,
Okay,
Dr.
sir.
Basavan. So
Okay,
now,
sir.
with your permission, I will take another questions. So please mute all of you, and I will request the person one by one. So there is a question, and I think that Dr. Sidharth may be able to tell about it. How long cooled RF giving pain relief versus thermal radiofrequency in sacroiliac joint? So it is open for all, but I will request that Dr. Sidharth if takes it. If you have any experience with the sacroiliac joint.
Thank you. So we have experience with it, but the only difference which is there is not in the how long the effect is there, but it is how more what is the percentage of success that can be improved with the cold RF,
Okay.
and that translates into a longer relief, not by virtue of the technique itself, because essentially the principle is same, but by virtue of having a larger lesion. So you can very well imagine that me, just imagine I'm a pain physician. I have a conventional RF, and I'm going to do a sacroiliac joint, and then I have to go to 9 o'clock, 3 o'clock, all the positions, then place my needle one by one by one by one there everywhere, and worse that I take in the OT. Okay, I'm working in a private setup.
Okay.
So if I just go with the cool RF, make a bigger lesion, place my all three probes in one go, do the big lesion, get the nerve in my lesion, and then I have a better result. So this is the advantage.
Okay.
If a patient is having, let's for example, two patients we did, one we did with RF, one we did with cool RF, both have good relief on day say 5 or 10 or 20. No, I have not read about any studies about the longevity difference, but from the conventional, wisdom, I think other speakers can add later on. But I don't think there will be any difference in the duration of the relief, any significant difference.
Is there
However,
anything?
it makes a lot of stuff, for you while doing it makes a lot of easier for the physician, and your chance of getting the SI joint is multiplied. You increase your chances of success.
Dr. Sidharth,
That's what it does.
literature says anything about it? Dr. Sujeet, you can also please pitch in. If you there is there any literature which says which modality gives longer duration? Because question was longer duration. I could understand that what Sidharth has said, that the chances of success is more with the cooled RF for the sacroiliac joint per se. Is there anything which literature says, Dr. Sujeet or Dr. Sidharth or Dr. Mitesh? If no, then we can go ahead with the
I'm not aware
conclusion.
of any such
The
literature, but
longevity to the literature
I'm not aware
still,
of any.
the studies are still going on. There are not much literature available.
That's wonderful. That's
But
okay.
since the larger, the lesion, the larger, because the sacroiliac joint and lateral branches of the ramus of S1, S2, S3, they have variability. So having a bigger lesion with a cooled RF will give a better result.
Okay. Then it's summarized. Dr. Sujeet, Gautam, would you like to add anything?
Well, presently, we have somewhat limited evidence available as far as cooled RF is concerned at the moment. Definitely, initial evidence is promising that as with respect to mechanism, what the cooled RF proposes, the duration of action is supposed to be longer as compared to thermal RF. But definitely we need to see somewhat more interesting studies in this. But presently, as of now, what Sidharth and Amitesh are saying is appropriate.
Okay. Thank you, all three of you. The next question is slightly technical one. I am afraid that whether anybody would be able to answer it. What are the probe placements for the cooled RF ablation of S1 to S3 REMI for sacroiliac joint pain? So, if anybody of you like, you can pitch in, please. Dr. Sujeet, Dr. Sidharth.
I'm not doing.
Okay, Dr. Sidharth, I think that this question is slightly difficult to answer because there are multiple ways of doing the same thing. So, Sidharth, would you like to say anything?
So that it all depends on what you are, you in the first case, like when I did was I started with I had a conventional single channel machine.
No. Sidharth, the question is very specific. Please stick to that. What is the position for cooled RF probe for S1 to S3 REMI?
So the position doesn't vary. It is the same as you will do it for a conventional RF.
Okay, you will put it bang on perpendicular to the bone, you know, because it makes a bigger. Thank you for that. So then there are a lot of questions. I don't know how much. So there is this question is for Dr. Sujeet Gautam. How much size can be increased by giving normal saline NaCl? Any clinical paper comparing thermal versus cooled RF? Yeah, this question. Part of this question has been already answered by Dr. Sidharth. So, Dr. Sujeet, what is your opinion about giving the normal saline before doing the RF lesioning?
Well, the authors have said that the lesion size increases from the range of 30 to 150% with different duration of action and different needle sizes. Okay. So it is the range they have suggested from 30 to 150% as compared to without any saline.
With the amount you have already mentioned, around 1 ml.
0.7 ml.
0.7.
Yeah.
Because of electrophoresis and
yes. Dr. Jeet, you are saying something.
Electrophoretic analysis increase the size because of electrical field at the site of tip of your.
Yeah, that increases the size of lesion and terms in effectivity. Thank you very much. So we will go to another question. That this is question from Dr. Sanjog. How will we know on fluoroscopy that we have pierced epimysium? He must have this must be typo error or adipose tissue.
So I will like to take this question. So
yeah,
you will come to know, it's a very easy thing. You will know with the impedance. Okay. So you all the time, whenever you are pushing, you are seeing your impedance. Okay. So all these movements will make a lot of difference. So suddenly we are usually taught when we are close to the bone, you see the impedance, but there is an impedance change when you transit from the skeletal muscle to the adipose as well. So once you are joining the bone, you just split your electrode a little, and then you see how you are placed, and then you further improve your placement with the help of your stimulation and check the impedance. So it should be more than you will face a higher impedance than a skeletal muscle, but it will definitely be less than the bone.
Okay.
Well, I would like to make a comment in this regard.
Please.
What Sidharth has said is appropriately correct. Another important aspect is that your needle tip should be snugly in contact with the bone. So how to assess that your needle tip, rather the active tip, is actually at the side? So as soon as your tip hits the bone, you know that your tip is contacting the bone. Now, as you move your needle further, your movement conveys that you are strictly abutting the bone. So the basic idea is that your needle active tip should be in contact with the bone. So by simultaneously feeling the feel of bone while moving your needle little by little and visualizing this thing in the fluoroscopy that your needle tip hasn't crossed the boundaries of the bone. So with this, you can assess that your needle tip is exactly overlying the bone. But I must say this was a very nice question from the audience.
Yeah.
Very tricky one.
Thank you. Question was nice, so was the answer. Thank you for both of you.
Sir, I would like to ask the question, Dr. Sujeet or Dr. Sidharth. Do you have any suppose a patient on pacemaker? How can proceed for that, sir? There is any interference with this this machine, RF machine. Supposed to patient have one pacemaker.
So, Dr. Sujeet, please take this question that what about the patient on pacemaker? How can we do it safely? We can do the RF lesion safely.
Well, I feel like it is similar to the electrocautery. It is like the cautery one. Whatever precautions we take intraoperatively with the cautery, we should take, because we are giving the electrical bursts, and similar the cautery is also giving. So whatever we have to change the mode, just like we do in our routine surgical procedure. We have to send a cardiologist.
Whatever surgeon are using the electrocautery, they are using the more energy. So you are using the very minimal energy. So
by using bipolar.
They are okay. Please do not cross talk. It will be difficult to understand one by one. So, Dr. Paswan, I would like to add here. Energy is almost same.
There is no bipolar. Sir, one more question, sir. Is there a cooled RF in is any have a role over the differentiation pain?
No. There is no rule. Bipolar cautery.
Differentiation pain. I think anesthesia dolorosa, you can say. Differentiation pain. Is there any role of the cooled or
Dr.
PRF
Sidharth,
or
would
RF?
you like to take this question?
Yes, sir. So there is no role of any thermal lesioning in any case of anesthesia dolorosa. So you can only use neuromodulation or other biopsychosocial.
Sorry. Yes. Dr.
Yeah, basically, Dr. Paswan, the thing is that both the cooled RF and the thermal RF have got the similar mechanism of action. They are basically burning the tissue. So there is no point that they are going to have different effects in cases of deafferentation, in which there has already occurred some damage in the neural pathway.
So the solution for that is either you go for neuromodulation or you go for biopsychosocial.
Neuromodulation with PRF?
PRF, yes, but more than PRF, the peripheral nerve neuromodulation with the help of that is effective. PRF is less likely to give results unless there is a very specific lesioning where you have a DRG which is above that level of that lesion which you created for the first time.
Sorry, it is a wonderful discussion, but I think that we are off the mark of the today's topic. We will have another session on the neuromodulation where we will deal with this. For the baseline thing, I would like to add one comment about Dr. Paswan's question. It's a very important question, but as the old senior always taught us, Dr. Rastogi has always taught us, whenever there is unfortunate complication like the anesthesia dolorosa, do not go near the patient with a needle. Use it either with the drugs or your neuromodulation. So we will stick to that, and we will go for the another question. But thank you all for this is a question rather than this is a comment from Dr. Leena, perhaps from somewhere outside the country. For shoulder, we use PRF. For hip, femoral nerve, and obturator nerve, also we use PRF. So, is there an experience of our speakers, esteemed speakers, on the PRF use for the peripheral nerves? I think that is safe, certainly, but please. Dr. Sidharth, would you like to say, or Dr. Sujeet?
So, sir, any mixed nerve, the PRF is usually used when you are, you want to preserve the function of the nerve at least partially, or there is a definitive evidence of the use of the technology, which is very limited. So, I will like to use PRF only in the cases like, for example, this suprascapular nerve. You know that it's a mixed nerve, so that's why we want to preserve the motor function, while at the same time we want to induce the changes so that the pain is reduced. So that's how we use the PRF, and it works good in practice of many of our colleagues. However, personally, I have started using thermal RF in even suprascapular nerve for long. I use a temperature of a lower temperature, and there are incidences where people use it. So it depends on how you want to place the thing. There is no definitive evidence in any of these, hip as well as the suprascapular nerve. Usually you will find in your clinical practice, RF will give better results, but at a loss of, probably a risk of a loss of the function.
Thank you. So that summarize the question. There is one question from Naga Lakshmi. That the PRF is not giving good results. This is the pain of many of us. Any other alternative? and he or she, I don't know, he doesn't seems to have a cooled RF. So Dr. Sujeet, I would like you to answer please this.
Regarding pulsed RF, my experience is limited. I'm using it only in cases where cases of mixed nerve, but my experience is pretty limited as far as, because I'm not very much in preference of using pulsed RF.
Okay, that's it.
RF, if I use, most of the times it is thermal, and only in recalcitrant cases I prefer to go for pulsed RF where there is a mixed nerve. But my experience is limited.
No, if someone is not having cooled RF, then there is one option you told for using the bipolar RF by using two needles, I think.
So you are asking about pulsed RF or cooled RF?
No, the question was that pulse RF is not working, doesn't have cooled RF. So what are the options?
Okay. Thermal RF and bipolar, you have said if the facility is there, definitely it's an option.
It's an example. Yeah, it's an exciting one. Thank you for that. And another question. Yes, this is very interesting question for Dr. Sujeet Gautam. That you said in your presentation that in order to improve the size of lesion, you asked to make two lesions with a curved tip needle. Before giving first lesion, we inject some local anesthesia. So how can you be sure that after curving the needle or pulling it back slightly or rotating the needle, do we need to give another shot of local anesthesia to decrease the procedural pain?
Yes. Yeah, this was a very nice and tricky one. So
Yeah.
what I suggest is that if you with a curved needle, if you want to produce lesion in two directions, before giving local anesthetic, go for sensory and motor stimulation in the both directions.
Okay.
And this is one option you can adopt because your needle position is fixed. So to pre-check before giving local anesthetic. Now, if you are coming out, then definitely there are chances. Basically, we adopt this practice more so in cases of facet joint, as we have suggested, and like in trigeminal neuralgia, because as we withdraw, we produce lesioning. They have got sensory and sensory fibers only. So in those cases, we can adopt, but yeah, risks are there.
Thank you. It's a wonderful thing you have said. What you can do that before doing any lesioning or before giving any local, you can check the sensory motor stimulation in both the direction in which later on you are going to do the lesion.
Yeah,
exactly. It's a very insightful thing. Dr. Sidharth, I would like to pose one query here before our anesthesia residents gets like fed up with the too much of jargon of pain medicine. Like our society has made it desirable to attend by these webinar series for the anesthesia resident. What do you think is the logic behind it? Is it going to be useful for the anesthesia residents in future in their career determination and options?
Yes, of course. So I will like to thank you, sir, for asking me this question. So the thing is, as a resident, many of us have very limited experience in or exposure to pain medicine.
During your MD anesthesia time. Sorry,
yes, while you are doing MD anesthesia or DA or whatever, so or DNB. So at that time, even if your institute is having somebody who's working in pain, the quantum of your duties will not let you even, anesthesia is a very vast subject. You very well can imagine that, it's not only studying, so you have to study chemistry, mathematics, physics, everything. And then you are supposed to be the best one. And of course, we are working under our colleagues who are, in extreme stress of environment. So there is a paucity of time. So even if you are in an institution wherein the pain is the best in the country, still you may have almost zero exposure to pain. So this is the problem. And for this reason, it was a very good idea to for our society to come up with this kind of webinars which can give exposure, at least some kind of exposure. They can just while relaxing in their home or while in between the duties or whenever, they can have at least an exposure about what pain branch is about. And then of course, whosoever wants to ask any question, we are all open to answer and help, and I'm sure everybody will help each other, and then you can ask more questions about it. So I think
so you mean to say that they have to do their extra bit to get the exposure of pain medicine while in their residency?
सर देखिए बिना मरे तो स्वर्ग भी नहीं मिलता है. So
Yes,
you
yes.
need to understand that you need to, everybody wants to go to heaven, but
Yeah.
nobody. That's why I put the car picture in the end. I think the answers were not coming in the chat. I was expecting a more participative audience,
No,
but
no, it
I'm
will
sure
take
वो
some
chatting
time.
मुश्किल होगा.
Yeah.
कहीं ऑप्शन ही नहीं मिलता है chatting का. So that's why. But otherwise, if you want to buy a Mercedes top class, you have to have $200,000 in your account. Otherwise, you cannot buy it. So the कीमत चुकानी पड़ेगी.
Yeah, so it's like quite a reasonable thing, because everything best is the one who cooks on the slow heat, or for
Wonderful
better
comment,
things you have to pay more.
Wonderful comment.
Yeah.
Wonderful comment.
Thank you, Dr. Sujeet. So we are going for you question, Dr. Sujeet. There is that, sir, you said that any fluid decreases the lesion, increases, actually he wanted to write it, I believe, increases the lesion. So we can give local anesthetic or not? Or we have to use normal saline or some particular?
Basically, the fact is that NaCl has been found to reduce the impedance and thereby increases the lesion. So with sodium chloride, with saline, we can also inject local anesthetic.
So that will work the both.
Yeah,
okay.
sure.
There is a second part of this question asked by Dr. Raghav, that what is the maximum amount of local anesthetic while doing the lesion?
Probably, I have gone through the abstract. These are all the very technical articles. So I have gone through these articles only in the night. I would like to go through them once again, but they haven't mentioned the maximum amount.
Maximum dose. Yeah,
they have used only a predefined volume, and with that they have studied the various RF parameters and the lesion various RF parameters they have.
Okay.
And the needle parameters.
Okay, so the reasonable amount has to be given. You don't want to flood your patient with local anesthetic or normal saline.
Maximum amount they haven't mentioned. I was also looking for that thing, but they haven't mentioned that.
Okay, but they have told us the adequate amount, that is 0.7 ml to 1 ml at a single needle. You have already mentioned that.
I can't make a comment on that, because they have mentioned they have used 0.7 ml. What are the effects of injecting more amount? Because one thing what they have done in their ex vivo study, that they have done their studies on the chicken flesh, chicken breast they have done. And what they have mentioned is that they have produced the lesion immediately after injection, so that there is no diffusion of the fluid occurring. So this is what they have mentioned. So definitely there are many possibilities after this particular line. So if you are waiting, for example, afterwards, how much time one should wait, how much volume one should inject, these are definitely variables one should. But I'm surprised that I could not hear this kind of studies, because they have been published from 2012, 14, and 15, and it's a significant amount of time I haven't heard about.
Okay, thank you. Thank you for an honest answer. So there is another question for, I think Dr. Amitesh can take this question. What is the close proximity of probe during CRF and PRF with nerve? So Dr. Amitesh, this is the question. You are, please unmute yourself. Yes, please go on.
Question is, can you repeat the question?
Yes. This is what about the close proximity of probe? I think that he must be asking that how close to the nerve and RF probe should be in CRF and PRF, pulse RF and
pulse RF and the CRF. I don't think it much differs with the CRF and the PRF, the proximity to which you can go to the nerve. But the difference, you have the luxury with this, with the, I don't think it's a cooled RF. Okay. In the luxury with the cooled RF is there that you create a bigger laser. So you can be a bit away from the nerve. You do a sensory and motor stimulation of the nerve to check whether you are close to the proximity to the nerve.
Okay, thank you. So if I would like to just summarize this thing about
I would like to ask one question, sir, more, please.
Please.
Is there any role of, do you have any experience about the, I would like to ask the question from the Anurag also. Sir, is any role of the RF in the myofascial trigger point?
Dr. Sujeet,
nerve पे तो बहुत बात हो गई, nerve पे तो बात हो गई, but myofascial trigger point, is there any role or have you experience?
Dr. Sujeet.
Yeah, their isolated case reports are available if there are recalcitrant myofascial trigger points. There are few isolated case reports are there that you can have a trial of pulsed RF. We have used in one or two cases. In one case, we have got good result. In another, the result was not good. So this is what I have experienced about it and the literature.
So it is still in the experimental stage, I think.
Yeah, yeah.
More studies.
Which
but
one?
it is
Which one is the better? Which one is the better? Pulse, cooled, or conventional?
for myofascial.
As far as present evidence is concerned, only pulsed RF has been mentioned as a modality few in case reports for recalcitrant
Trigger points. Okay. Thank you. But this thought is very unique and important, Dr. Paswan. I thank you for that, for bringing this into the light. So another question for Dr. Sujeet. For pulse radio frequency, is it a need for local anesthetic for lesioning? Dr. Sujeet?
Yeah, we do inject, but we have always used local anesthetic prior to pulsed RF.
Okay, you use it. But what is the reason? I personally have a doubt about it because pulse RF is not painful. It is doing only the electro.
Few patients, what exactly happens is that few patients suggest somewhat uncomfortable sensations occurring. So to numb those uncomfortable sensations, we are using local anesthetic prior to pulse.
Okay.
So, sir, can I pitch in with this thing?
Yes, please.
I will tell you the what I have experienced. If pulsed RF, if you give the patient a local anesthetic, he is less likely to move because you don't want your needle to move once the lesion is in place. Number one, because the duration is longer. You're going to stay. We want him to be stationary till the 10 minutes or whatever time we are going to do it. Number one. Number two, for any needle we put in any patient, we are going to give the local anesthetic any which ways. Okay. So this is for the post-procedure pain as well. So these are the two reasons why I will always use the local in the pulse RF.
Even during the pulse radio frequency. That is very good. Actually, I would like to pose one question from my side, which just came into my mind about the pulse RF thing. What is like I have read somewhere that there is a difference between the pulse and pulsed RF. So do you think that is it important to fix the voltage while doing the pulse RF? Do we need to care about the voltage of the machine which it is delivering during the pulse RF listening? First part. Second part is the duration, about the duration. The conventional duration has been advocated with 120 seconds only. So do you think increasing the duration may increase the effectivity of the thing? So one by one, whosoever want to take the question. Dr. Sidharth, you start.
Yes. So for the pulse RF, the basic principle what the pulse RF has is that it induces a genetic modification in the milieu of the neuron. Okay. So in some way, this is going to the bouts of alternating current which we are delivering at 42 degrees Celsius is supposed to stimulate the axon into changing its expression of the receptors or its genes in some way. This is the basic mechanism which is right now agreed. It's not a 100% consensus, but most of the papers will agree on this. Okay. So if you are increasing the duration beyond a point, it will have no effect. But definitely, I will not like to do it for 120 seconds, which is quite a low. I don't know how Dr. Sujeet does it, but I will like to go with 5 to 10 minutes, which is which I use in my practice. Number two, it is all about delivering that particular current in the close proximity of the nerve. The same result has been achieved by percutaneous devices without any, which are non-invasive. Ours is minimally invasive, but similar results have been achieved in non-invasive. Like, for example, stim pod, which is available in India. For example, a lot of other things which people are using. So this is another alternative, which is better. There is no evidence, but the end result is delivery of that particular stage to that particular nerve fiber at that particular point and its expression in the DRG. That's it.
Dr. Sujeet, would you like to?
Dr. Anurag, I suppose Dr. Lakshmi Vas is with us and she was interested to make a comment in this regard. So
yes, please allow.
I will unmute her. Just
yes,
hold on.
please do it.
It's
Thank you,
Great
ma'am.
to have her in our forum. We should
Yeah.
hear her.
Yes, yes, yes.
Madam, I have unmuted you. You can speak now.
Welcome,
Can
Lakshmi
you hear
ma'am.
me?
Welcome, ma'am.
Thank you. Thank you. I came in a little late. So, but the
We'll put
question
the whole
on
video on the Facebook, ma'am. Don't worry. We will put the whole video on the...
can you,
Almari.
okay. Can you hear me now?
Yes,
Yes,
ma'am.
ma'am.
Yes, we can.
See, I do a lot of PRF and with very good results, I must add. And the very good results, I'll talk about it later. But I initially, for the first few cases, I used to give local anesthesia. Then I thought, why are we giving local anesthesia for something where there is no pain? So I don't give local anesthesia at all. But one of the problems is that these nerves, many times we do PRF for mixed nerves. So when you give PRF and you're close to the nerve, there are twitches coming on in the muscle many times. And these are uncomfortable for the patient sometimes, if it is too much. And it might also move your needle away because of the twitches. So if there is an uncomfortable level of twitching, then, which happens when the nerve is irritable, of course, then I give local. I may give just about 0.5 ml or something like that. That's it. And should I talk about why PRF works so well at our center?
Ma'am, we had a talk. Yeah, ma'am, we had a talk about it. We will use more of your experience later on. Thank you, ma'am. Thank you
no,
for
but
clearing.
let me make one point.
Yes, please.
No, let me make one point in a minute.
Please
That
go
is,
ahead.
see, Dr. Paswan was asking a question about myofascial trigger points doing
Yes,
a PRF.
Yes.
When you do a PRF or any neural procedure, you are clapping with one hand. You address the nerve, but you are not addressing the myofascial trigger points which are formed in the muscle. So any PRF, if you follow up with dry needling or Botox injection or trigger injections, your PRFs will start working. That's what I wanted to say.
Yeah, that is wonderful insight, ma'am, and wonderful tip for all of us. Thank you very much, ma'am, and we welcome you again on the forum. You are a very important part of our society. So I am, ma'am, with your permission, I am going for another question. We have got a lot of questions and they're coming continuously.
Please go ahead. I thought I should answer. That's why I asked you.
Oh, ma'am, it's wonderful, ma'am. That this is what this forum is for. We can, we want to learn from you, seniors and pioneers. Thank you, ma'am. So I am taking another question. This is actually a question is that from Dr. Sushil Jaiswal from Banaras that when we convert. Can we convert monopolar radio frequency into bipolar by changing the patient pad into the second probe? Is it effective? So I think this is a technical question. I don't have much of technical knowledge. Whether we can use.
Reply that for you.
Yeah, please, Dr. Sidharth.
So technically, I mean, theoretically speaking, it is effective, but technically you cannot achieve it. So I'll answer both parts.
Yes.
Number one is patient safety is concerned here. The electrode which is used is a disc. It has a very wide area of from where it receives the current, and this completes the circuit. Okay, in a way. So the problem with using the same thing with this is that you have not tested the same thing. It may work, it may not work, but then if it doesn't work, your patient loses something. Okay. And if he loses something, then probably you will also lose something sooner or later. Okay. So that is the only difference. Otherwise, if you see, many of the equipment providers, including the one which has cooled, including the one which was single channel, they all provide bipolar attachments with the same machine. You just have to purchase that. Okay. So they have a mode wherein you can use the bipolar attachment, and then that's it. That is actually verified. And if with that, if patient has harm, not going to ask you, because that is a standard benefit. I mean, harm of the, you can say the side effect of the procedure or a complication, known complications. But if you do this all experiments in a patient and you've not taken his consent, and by chance there is a spark or something, and you are near some cervical,
then you are in the soup. So what I understand that do not play with the machinery by your own. because this is the time of evidence-based medicine and medical legal issues both. So we have to take care. So better to have the good equipment at your hand.
You can damage your equipment as well.
Yes, yes, same time. Thank you, Dr. Sidharth. So there is another question from Dr. Nagalakshmi to everyone. Which temperature do you use? I thought I am going to take this question for myself. That temperature will depend on the area you are doing the lesioning, the type of lesioning you are doing, and for the purpose you are doing. So that will vary. You need to go through the literature. For shoulder, Dr. Preet Anand, this is, I think, not a question, rather a comment from Dr. Preet Anand. For shoulder, do the suprascapular nerve and axillary nerve both for the better results. Okay, Dr. Preet, we will try and do this. Another question is from Dr. Shiv Perumal. Is it advisable to use opioids as pre-injection before RF? I would like Dr. Sujeet to answer this question. Do you find it so painful?
In the study,
yeah, please come again.
Basically, the studies they have mentioned.
They have mentioned no. Your audio is going.
They have concluded on two aspects.
Mm-hmm.
So the thing they have basically discussed two factors. One is that the effect of injecting any fluid, and second question what they have addressed is that effect of any benefit to be achieved after injecting sodium chloride as compared to other fluids.
No.
So the first part,
Dr. Sujeet, I would like to interrupt. Question was about using opioids as pre-injection before radiofrequency. Not about any.
They haven't studied. They haven't made any comment regarding the opioid. They have studied the fluid and specifically the sodium chloride. And hydroxyethyl starch also they have studied.
Okay.
So they haven't studied the opioids.
Okay. Thank you. Another question is for Dr. Amitesh Pathak. This is post-injection, post-radiofrequency injection of steroids. Have they any beneficial effect? Dr. Amitesh? Do you give inject
post-radiofrequency injection of steroid? It can reduce.
Pardon?
Yes. It can reduce the steroids. No, I don't use after putting radiofrequency. I don't use steroids. There are some studies which suggest that the effectiveness, if there is any neuritis chances of neuritis, if you suspect the chance of neuritis will be there, you put a steroid. But in my clinical practice, I don't use it.
Okay. So, Dr. Sujeet or Dr. Sidharth, would you like to pitch in? This is an important one because I have seen 180-degree type of things happening with this thing putting steroid after radiofrequency. I agree when they put it on the facet RF, but I don't agree personally when they put it in the Meckel's cave after doing radiofrequency for trigeminal neuralgia. I am a little bit too scared of putting steroid or anything else in the brain of patient. So what is your take upon this? This is a very important and good question, Doctor. Thank you for asking.
Yeah, I completely agree with your comment regarding this pertinent point. And we have somewhat changed our practice somewhat over the past one and a half years. Previously, we used to inject non-particulate steroids, especially in cases of facet joint and a few other areas where we know that vascularity is not much of a question. But now for the past 1 year, we have switched on to, we were using particulate steroid. Now we are using non-particulate steroid. So dexamethasone, we have changed our practice to non-particulate steroid presently.
Even after trigeminal, my question.
We are not injecting anything after trigeminal.
Okay,
that's why I said I completely agree with you.
Thank you. Siddharth, would you like to add something or I will go to another question?
Sir, you can go. Yeah, we do same. Trigeminal, no injections.
No injections. No
we can,
steroids.
yes, or even if somebody is using the steroid, then also it depends. If you are using dexamethasone, that's altogether different story than if you are using a tamsulone or some. Yes.
Okay. This is Siddharth for you. You have said that you are using conventional RF for the suprascapular nerve. What is the temperature settings you are commonly using?
So 60 degree, 90 seconds, followed by 60 degree, 60 seconds. So this is 2 lesions I do. And this is my routine practice for like now since the ICRA was in Jammu. So like it was like three years now.
Okay. And you haven't found any complication like the motor weakness, which is people are scared of. So you are doing partial lesioning of the suprascapular nerve. Oh?
Yes, because earlier I was doing PRF and I was getting mixed results. I was never able to convince my patient that to accept those kind of results. So with this, the patients are pretty happy. And as Dr. Preet Anand from Singapore has mentioned that this we combine it with the axillary to get a good result.
Okay, that's great. So another question is role of PRF for DRG in post-herpetic neuralgia. Dr. Sujeet, would you like to take this?
No experience. No experience.
No experience, but still, I think that PRF is pretty harmless, so it can be used if possible. If you can reach the DRG, so I think there is not going to harm, at least if it is not going to benefit.
Here, if you permit, I will like to add.
Yeah, please go on.
So first is you don't get this herpes usually in the L3 or L4 or L5 levels. Okay. So whosoever asks this question, I'm sure we will encounter a lot of difficulties in approaching the DRG, because at the higher levels it is inside the foramen.
Inside the foramen. Yeah.
So to achieve it from you will come very laterally. I have tried these procedures. I have even done a few, but it is extremely difficult. High skill is required. And
no. Considering the question that perhaps he can reach the DRG, then you tell whether to do the PRF.
Okay, even if you reach the DRG, the evidence, I have read a lot of papers on this, and the evidence is not unequivocal.
Very great.
Still, it's not supporting, it's not refuting. So it is a few case reports.
Experimental again.
Yeah, so it is just, you cannot offer. The main harm which it will do is not to the patient, but to the pain physicians, because you lose your chance to benefit the patient. And once you lose that chance, then probably the patient is going to look for other options. Okay.
That's great. I am very happy to inform all of you that we have planned this meeting for 1 hour only, from 11 to 12. Now it is 1:45, almost 2 hours, and I am still getting the questions. And it was a wonderful response from all the audience. And I would like to thank all the esteemed audience, and especially our esteemed faculty, Dr. Sujeet Gautam, Dr. Sidharth Verma, Dr. Amitesh Pathak, and especially the moderators of this session, who wonderfully moderated and participated very actively with the whole idea of radio frequency technique for the pain physicians and residents of anesthesiology. Dr. Ajit Kumar and Dr. Anil Paswan from BHU and Dr. Ajit Kumar from AIMS Rishikesh. I would again like to thank, I think if there is any comment, I would welcome it. Otherwise, we are going to close this meeting. Wait for another one. We will come with another topic of interest. Most likely it will be on the percutaneous spine endoscopy, advanced and future of the pain physicians across the world. And we Indians are certainly one of the leaders in this currently in the world, and we will remain so. And I would like to thank Avanos for participating, and you will be very happy to know that we have got participation from across the world. And as a secretary of Indian Society for Pain Clinician, I would like to thank our founder president, current president, past president, and president-elect, also Dr. Lakshmi Vas especially, and all of you, all the committee and all the participants. So with your permission, I am going to end this meeting. Thank you all. Keep yourself safe in these are the difficult times. This is our humble attempt to spread our knowledge with each other distantly, but we feel that we are very close and sitting next to each other. So thank you for your participation and waiting to see you again in the next meet. Thank you, Dr. Sujeet.
Wonderful coordination, Dr. Anurag. Wonderful coordination.
Thank you. Thank you.
And wonderful effort.
Thank you.
Thank you. Thank you all.
Thank you.
Thank you, Sidharth. Thank you, Amitesh. Thank you, Anil. Thank you, Sujeet. I am closing the meeting now.